determine that arthroscopically is to look at the shape. If the shape looks different, where the glenoid at the bottom is narrower than the glenoid at the top, then you've probably lost a significant amount of bone, and we'll come back to that a little bit later. So that now puts us back, brings us up to the current state of the art, where now we need to know when our patients may do better with an open procedure. We need to know what the relative contraindications are for an arthroscopic shoulder stabilization. And we also need to know if there's any absolute contraindications to an arthroscopic shoulder stabilization. I would present these as some relative contraindications that I use in my everyday practice. And I put these on a slide just to make you think about what your relative contraindications are in your practice. Young patients, I put the age 20 because there's a scoring system that uses that age as a cutoff, and we'll talk about that in a little bit. Contact sports, some people say throwing sports, but certainly contact sports like rugby, American football, or wrestling may be a relative contraindication to an arthroscopic stabilization. The type of instability, some patients that have hyperlaxity are multi-directional instability patients. Those may be patients where we want to consider not doing an arthroscopic stabilization. Tissue insufficiency, and really what I think about when I see that is patients that come to see me that have had the old-fashioned thermal capsulorrhaphy, where their joint capsule is no longer there. Those patients have a big problem. Often they're very young and they don't have any tissue to work with. So an arthroscopic approach may not be effective. A Hill-Sachs lesion. I don't think a Hill-Sachs lesion is an absolute contraindication. I think it's a relative contraindication based on the rest of the bone loss. And then in revision situations, that may be a relative contraindication also. If somebody's had a good shoulder stabilization arthroscopically and they failed, you may want to think about doing something different the second time. I do have one absolute contraindication, and for me that is significant glenoid bone loss. And so if I'm going to make that statement, we need to define what significant means. We also need to define how we assess bone loss on both sides of the joint when there's a Hill-Sachs lesion in conjunction with a glenoid bone defect. I think the glenoid is so important because we do not have a good arthroscopic technique to replace glenoid bone. I know there's some surgeons, primarily in France, that are wizards with arthroscopy, and they can do arthroscopic latargés, but for most of us, that procedure isn't yet at a stage where we have long-term clinical results to show that it's better to do that arthroscopically. With Hill-Sachs lesions, we do have a very good arthroscopic cure or fix for patients that have medium to large Hill-Sachs lesions. So I think that the glenoid is by far the most important part of the joint to assess for bone loss. So if we're going to look at the glenoid, here's some of the reasons why we do that. Many, many published studies have shown a significant decrease in success, starting at as little as 20% of glenoid bone loss. And I've listed 3 of them just for your reference. So that makes it easy, right? Now that we know if we can measure 20 to 25% bone loss, those patients go to an open procedure. If they have more than that, the patients that have less than that, we do arthroscopy, and we're good. Nothing else to worry about. But we still have to consider all of the other issues. Even measuring bone loss is not as straightforward as you would think. We also have to consider the Hill-Sachs lesion, and we also still have to go back and think about those relative contraindications. How do those figure into the surgical decision? So in measuring glenoid bone loss, you can do this radiographically. I think we're all familiar with the West Point view on the left. You may not be as familiar with the Bernagé or Bernagé view on the right. Both of these views are designed to show us the glenoid on profile so that we can measure how much anterior bone is missing. We can use an MRI scan. Most of us get MRI scans in these situations because we're looking at the soft tissue injury. And so we can use the MRI scan to help us assess the amount of bone loss also. Now, there are studies that show that MRI scans are as accurate as CT scans in assessing glenoid bone loss. But there's other published studies that show just the opposite, that CT scans, whether 2D or 3D reconstructions, are better than MRI scans. And I could literally spend all 10 minutes going through 50 published studies, 25 showing MRI is equal, 25 showing MRI is not as good. The one thing I wasn't able to find, I didn't find a single published study that showed that MRI was better than CT scans. The studies that support MRI all say it's equal. No one says it's better. So given that, you have to scratch your head and kind of wonder, do I just go with what's considered the gold standard still, which is the CT scan? And so this slide looks very busy, but I think it introduces a very important concept if you're going to measure bone loss before surgery. On the left is a 2D CT scan, which is sufficient to measure bone loss, but the concept is the inferior glenoid very closely approximates a perfect circle. And so if you place a circle on that glenoid and look at where the bone is missing and make a measurement of that area versus the area of the glenoid that's intact, that will give you a percentage of bone loss. Okay? Another way to do it is to draw a line from the center of the glenoid to the superior aspect where the defect starts, and then draw a second line from the center of the glenoid to the inferior aspect of the defect, and you measure that angle. And there's a nice formula where that angle is converted into a percentage of bone loss. Why can't we measure it arthroscopically? Well, it would be nice to know if there's significant bone loss before we get into the operating room. But once we get into the operating room, there are ways to confirm the bone loss. Steve Burkhardt has talked about looking at the bare area or the bare spot in the glenoid. And his belief or his comment is that the bare area is essentially right in the middle of that circle. And so if you can see the bare area, then you can measure the bone from posterior to the bare area. And let's just say that comes out to be 14 millimeters. And then you measure the bone from the bare area to where the bony vein card starts. If that area is less than 14, you know you've lost some anterior bone. And depending on what that measurement is, you can make a percentage calculation of how much anterior bone loss you have. The second one at the bottom of this slide, the secant cord theory, is a little more involved. It involves a little more math, and I don't want to be a mathematician in the operating room, so I tend not to use this. But it's based on the concept that if you draw parallel lines through a perfect circle, you can measure and estimate how much is missing. And I'll leave that there for your reference. The bottom line, and probably the most important take-home message, is that the margin of error is still relatively high, up to 4 percentage points. Even with the secant cord theory, which is supposed to be more accurate than just measuring the central bare area. If you use Dr. Burkhardt's technique, you will tend to underestimate the amount of bone loss. I'm sorry, overestimate the amount of bone loss. Okay? So if you use Dr. Burkhardt's technique, where you're looking at the bare area and measuring from posterior to bare area and bare area to anterior, you will overestimate, on average, the amount of bone loss. And so as long as you know that, you can make your adjustment. If you measure it, it's 25%, but you know that you're probably overestimating a little bit, you can make that adjustment in the operating room. The important thing to remember arthroscopically, and this is what I really do in the operating room, I don't worry about doing all of the math and doing calculus and trigonometry. What I do is I measure that distance from the posterior edge of the glenoid to the bare area. And again, I'm going to use the number 14 millimeters. If I measure 7 millimeters or more anteriorly, I know that I have at least 50% anteriorly, which is okay, because the graph on the right shows me that if I have 50% or more of the radius, then I haven't lost over 20% of the glenoid surface. So as long as I have at least 7 millimeters anterior, then I'm okay. And I can do that very quickly without doing a lot of math in my head in the operating room. If I measure it and it's only 5 or 6, then we have a problem and I need to consider doing something different. This would be something different. So here's an example where the measurement may only be 3 or 4 millimeters anterior to the bare spot, and as a result, in my current practice, I would move on to a modified Latarjet procedure. That amount of bone loss needs to be reconstructed, in my opinion, to get the success rate that we want. So are we finished? Now we know how to measure the bone loss. Now we know what to do for patients that have less than 20 to 25% and more than 20 to 25%. But we still haven't talked about the Hill-Sachs lesion. What do you do with the Hill-Sachs lesion? I would suggest, and this is just my opinion, so if you're ranking the levels of evidence, this would be level 5 or 6 or 7. But I would suggest that the vast majority of Hill-Sachs lesions, especially those that occur with minimal or no bone loss, can best be treated by ignoring them. Do not do anything. It's not helpful to control pick them. It's not helpful to do anything. You can look at it and then move on and fix the bankrupt because they don't affect the clinical outcome. Preoperatively, we can get x-rays to look at the Hill-Sachs defect, and the CT scan will show us large defects very nicely. The concept is that of an engaging lesion. If that defect in the humeral head is so large that with the patient abducted 90 degrees, they start to dislocate with a little bit of external rotation, then that becomes a Hill-Sachs lesion that you may have to pay attention to and treat surgically. Some surgeons believe that all Hill-Sachs lesions have to engage to create the Hill-Sachs, and I think that's a valid point. But I think the real message is that there are some lesions that get so large that even with a successful soft tissue surgery, a successful arthroscopic bankcard reconstruction, that patient may still have recurrent instability on the basis of their Hill-Sachs defect. If you feel you have a patient in that situation, there are several things you can do. This is a nice paper from John Richmond, who uses an ACL guide. So if you can get an ACL guide, you can do an open procedure, place the guide on the back in the defect, and drill a guide wire from anterior, basically through the lesser tuberosity, and drill over that guide wire with like a 7 or 8 millimeter drill. You can take an impactor, punch out the Hill-Sachs defect, and bone graft behind it. And those patients in his series do very well. Obviously, much more invasive than an arthroscopic procedure. There are other options. If it's a very large defect, you can do osteochondral allografting and other techniques. Arthroscopically, this is what I like to do. Now, this is what is a remplissage. So if somebody has even a large Hill-Sachs defect, if they have lost less than 20 to 25% of their glenoid, I still get very, very good clinical results. These have been published as well, by doing this procedure instead of transitioning to an open lateral. The Hill-Sachs procedure, the remplissage procedure, is an old procedure. It's described in textbooks as far back as Near and Rockwood. And basically, we are just placing a suture anchor in the defect and suturing the infraspinatus and posterior capsule down into the Hill-Sachs defect to make it an extra-articular defect so that it doesn't engage and the humeral head can no longer dislocate because of the Hill-Sachs. So there's an example of a suture anchor, and there's a surgical example on the right. Okay, so if we go down the algorithm, we can now add a remplissage for medium to large Hill-Sachs. If they have a small Hill-Sachs, I don't do anything. Nothing. If they have a medium to large Hill-Sachs and I feel compelled to do something in addition to my bankcard, then I will do a remplissage procedure. Okay? If they have a lot of bone loss, we're going to an open ladder J, regardless of the Hill-Sachs. But now we have to talk about the relative contraindications. So 2 more slides and we'll talk about this. The ISIS score was published by Pascal Below and one of his colleagues back in 2007. And this was an attempt by Pascal to summarize all of those relative contraindications into one nice scoring system where when you crunch it all down at the end, all you need to look at is this number 7 or is this number 6? Because if the number is 6 or less, we can proceed with arthroscopic stabilization. If the number is more than 7, then in his series in France, 70% of those patients failed arthroscopy and needed a ladder J. So as you look at the ISIS score, he uses the H cutoff of 20. He uses 2 different criteria for sports, one being a competitive sport, not a contact, but competitive sport. The other being an overhead sport, okay? He also has a criteria for hyperlaxity. He has a criteria for seeing the Hill-Sachs. He has a criteria for the glenoid. So it's a clinical and radiographic score. And I do not use this as my only criteria. I use this in combination with my history and physical exam, and particularly with the amount of glenoid bone loss. Okay, so putting this all together, if I have a patient in the operating room, and I'll have this conversation before surgery, we will look, if you are between 20 and 25% bone loss, in other words, you're right on the margin of what is acceptable, in my opinion, for arthroscopy, and you're 15 years old and you play American football, we're probably going to go to a modified ladder J. Okay? If you're 29 years old and your ISIS score is 4 and you have 25% bone loss, we can do a Bankart and a remplissage if necessary and still get very, very good results. So I use that ISIS score really as a tiebreaker, if you will, in patients that are really on the border in terms of age or their physical activity when we get there in the operating room. And it's important to have that conversation ahead of time because you don't want the patient to wake up with a scar that you never talked to them about. So in conclusion, I hope this presents a reasonable review of what I'm currently doing in practice. I, like all of you, will change my mind if the facts change, so we always reserve the right to do that and to progress. So, muchas gracias.